do a fusion of the technique, and then we have, the problem of we have damage all the muscles and the spine to do one fusion. So I want to talk with this case. I like to do this case even yesterday because it's challenging. This case is a 78-year-old female patient. I'm very sorry. 78-year-old female patient. The challenge in this case that regardless that she's old age, she has a lot of medical comorbidities. One of it, end-stage diabetes. So that end-stage diabetes is bleeding and infection, and the other issue, she's more than 145 kilograms. She's very obese. She has also neurological restriction weakness. So this is the outline. So I want to tell you what to do in this case. Two ones. I will not take too much for discussion. We don't have time. This is the case. So I will not discuss now what to do in this case. But at the end, we have two things important in this case. First of all, to do decompression, and the second, to do the spine stay, because the decompression will take everything from the back and external facets. Whatever the case, we have to open because the canal is very small. So what we do, what is the course spine fusion? Every time. What we do in spine, we decompress, we fix stability and alignment for deformity. This is the that we have to do. And what we have to do, we have to remove all the disc and in the place to be clear, and then to do the alignment, we restore the disc height with restoring the sagittal balance, and then we put our polygraph with the cage, and then we have successful fusion. We know from the basic principles of the spine, and the rate of fusion is high. Even if you go to the studies, you will see a lot of things, maybe in this way and that way. But in the principles of orthopedic surgery, if you have very good cancellous bone is excellent, and you see it all, like the cervical spine. And the other issue is the bony graft, and the size of the cage is giving you more rate of fusion. This is the difference between ALIF and the cage. ALIF and PIVOT is very useful. All the PIVOT, even the PIVOT, because the corridor is very small. If you go out of my ass or you go PIVOT, you have about 1 centimeter, 1.5 centimeter to put your cage. So this is a small cage. This is polyp. It is about all the cages of the ALIF organ, and how much? It is 1 centimeter by 1.3, 1.5. It's a polyp. In between, this new one is about 2 centimeters and going for 4 to 5 centimeters. So a very big cage. And this cage sitting in the cancellous, in the cortical bone. Usually the bone small is going inside the cage, so it's in the cancellous. But this one in the cortical bone in the vertebra, so the subsidence rate is this. There is some subsidence, but it's this than the other small cages. Now, the pseudoarthrosis rate, the spine is high. This is not good. It's about more than 20% in the case in the revision, to do revision cases for it. Now, this is favoring the anterior surgery, that the anterior surgery in revision surgery has higher rate of fusion and better sagittal alignment. Now, what is the consideration in this technique? That we have some MRIs and we have a lot of cases. Now, what is the percentage of these cases to have indirect decompression? So what's the meaning of this? That if you have collapsed disc and then you open the disc itself, the posterior and anterior ligament, longitudinal ligaments are very strong ligaments. So if you tighten it, everything goes inside. So any stenosis from the posteriorly from the disc or posterior longitudinal ligaments will go anteriorly. And if you have collapsed disc, the facet posteriorly is going down. So we have bulging even of the capsule joint. The capsule is the joint. So if you tighten it up, the same. So this is indirect decompression, and the percentage of these cases is good. In my daily practice, around 40% of my case, I don't do it direct. I do indirect only. So I put my case from a small incision, 2 centimeters, and I put percutaneous screws, and this is the surgery. And it takes, by time, it takes very short time. This is the axis So what you see, if you see the case, so if you do the MRI, and this is the axial view of the MRI. As you see, that this is the psoas muscle, you can see the psoas muscle bone, and you can see the aorta where it is. And between the aorta and psoas, there is a small space, and this is the vascular space. So you are, here is the psoas and here the aorta. And this is your carotid to go inside. So we can put the cage oblique, so going from one side to one side. This is the ALIF. It's not doing the cage from as the XLIF or the ALIF, which is going through the psoas. So as example, the other technique, the other techniques, you are going through the psoas, as you see. You need spinal cord method to see where is the lumbar plexus, and then you put your retractor and you put the cage, and going exactly from side to side. However, the oblique is going inside exactly from oblique. So if you see the other side is the nerve root or the foramen. But now we do it in a modified technique. What I do, you will see it now in the cadavers. We put our finger just under the psoas, and then we reflect the psoas. So we can go even without touching the psoas, we can go immediately to the vertebral disc. So we have to see in this MRI, because there is a lot, it is sometimes, the psoas muscle is very big. So it's like Mickey Mouse if you see the face. This is the face, and the ears is very big. So we can go to the anterior third of the psoas and go from there, from this. Now, the lumbar plexus is only in the posterior third of the psoas muscle, the lumbar plexus, especially at L4, L5. L3, L4 is more posterior, L12, L3, you are completely safe. The problem only in the L4, L5. So this is the standard zone. As you see, in the lateral, the zone, the standard going from end to end, from lateral to lateral, the oblique going oblique. But we will see it in the cadaver that we can put even from as a lateral exactly through the approach. Now we will talk about the procedure itself quickly because of the time. So what we can do everything. We can do, as example, degenerative scoliosis. We can do fusion for primary, non-new, and adjacent recurrent liver. Whatever the case that we need to do without, if you want to move without to have something like tumor, you can do it. Whatever the cause with the audit. Now, contraindication, there is no too much. The most important for me, whatever the ileus size and what it is, big or small, you can go through the psoas and you put spinal cord monitoring. The only one that I don't like it is this is one of my cases that happened with me. I did the indirect decompression. Then I have severe radicular pain. When I went from back, I saw that there is osteophytes in the posterior. This is the osteophytes. The osteophytes going and take the nerve root. You see the foramen? Here, there is osteophytes. If you do scratching, hooking the nerve root up, and you have the pain. This is that you have to see. You have to suspect it. And even though after that I went with my tube and I removed the osteophytes and everything worked. So this is the difference. That in classical surgery you have to do damage, and in this one you don't control. You just put your screws, and because anterior you can put the bone and the cage from the front. The concept is fusion, and there is the fusion bone to bone with bone graft with very good space that we do in this surgery. So what is the advantage? As you see, it's real this soft tissue damage. I can tell you that one level on it, you can send it outpatient. You know, and it takes about 1.5 hours maximum, and then at the evening, if he's good, he can go home. But even the most major surgeries know if there is no medical comorbidities and the patient is good, stay 1 night and maximum 2 nights. Never ever more than 2 nights unless we have other medical comorbidities. Now, this is the setup that we see inside. There is the retractor, special, you will see it, and there is special curate. You know, as you know, in the cervical spine or anywhere, or in the field, you need to clean the end plates, and this is the tools for the end plates. This is very important. Now, spinal cord monitoring is a must. Regardless, you have to put it because you need it and you can be more safety to it. About the X-ray machine, the C-arm is our, our fighter, this is that we work with nowadays. Now, to tell you that there's navigation, yes, there's robotic, yes, this navigation, yes, but till now we are working in this. Now, pre-planning, as we said, we have to see these structures, the source, the aorta, the foramina, where is our entry, how to go, and this is the most important, to find the vascular wind, the skin vascular wind. Even sometimes we find the aorta going in more lateral, you have to go more lateral. The aorta is away, you can go very safe. But the lumbar plate, which is the most important, is going in the posterior plate to be away from it. The position is completely lateral, as you see. We put the patient lateral, it doesn't need to break the table. Why lateral? Because we have other nowadays, ALIF, you have to have two positions. We go to the cage and then we flip the patient and another, scrubbing and toweling and with the screws. By the time it doesn't take with me, an example, time, because all the stuff that I have or the team, within minutes they understand what they do, so they do it quickly. But some surgeons, they do it, even in one position, which is the lateral, which is supine position. So look how, this is the one observation that I did CT scan. Look how much, all the visceral or the abdominal viscera, whatever, intestine, when you go lateral, how much is the access is easy. You see? There is, very short. So even nowadays, you will see today, even it's a cadaver, it's not loose tissue. It will be a little bit, because it was very, from the eyes or from the hole, it's sticky, but in the reality, when you put your hand inside with the peritoneal fat, everything is going down. Whatever. That's why we don't have a problem with very obese. Because the obesity is in front, not in the back. So if they go like this, you put your finger immediately inside. So it's very good indication for this. This is the key. Most important, the position in the X-ray. So you have to see the end plate spiral and this appearance, the vitical is like two eyes equal and in between the nose. You have to see it in this to be sure. Why? Because you are working vertical. So what we do, the table, we tell the table back in this side or up and down to reach this, clear parallel intervertebral disc. So if you do it like this, so you are working exactly vertical to the ground, vertical to the table. And the X-ray, the machine is vertical, but the table that we change. Now this is the one, usually we take exact intervertebral disc and we do our marking where it is, and from the middle disc till anteriorly we have 5 centimeters. And then this is the entry point. We have 2 incidents, oblique or transverse or very good. And this is that we go inside us. Yeah. So we have these muscles, skin, fat, then we have the external oblique muscles, then we have internal oblique muscles, and we have transverse abdominals, and we go to the fingers, stripping, nothing else. And then with our hand going to the psoas muscle and at the tip, exactly the vascular window, then we go to the disc. And with our hand you can see everything like this. This is the probe of the spinal cord monitoring that we put it inside, and if there's any near, your team will tell you that you are near in any, you are located in So I want to show quickly, this is the incident, and usually I do exactly less than 2 centimeters. I don't know. There's a big difference between audit and audit to the end. So I don't believe that we have more than 5 centimeters. In the reading, yes, you can do it. But if you need minimally invasive, should be minimally invasive. oblique, this is external oblique, internal oblique, and then we have the transverse size. Only we do stepping and put your retractor inside. And after that, because we do it now, before we finish, and after that we go inside, and then you can see the peritoneal pad. This is the pad, and after that you put your finger, and this is from the cadaver. If you see, we're going. This is the iliopsoas on inside, and this is a lumbar piece. Lumbar piece. It was with the needed a lot of pairing the left side and weakness of the psoas, but with the OLIF it will be this. This is a technique that we put the keola. After that, there is the dilators, and after that, this is the dilators, and then we put the retractor. You can see with the probe where the muscle inside, and we clean the disc space as any disc space as like the teeth, and then we start to put our sizes, how is the size, and then we put the cage, and that is the technique. Okay, so we have to go. We have a little case to talk, but not just when I want to show you